The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Welcome back, everybody, to the podcast, the Success in Practice podcast. Today, I'm joined by Jon Pitcher. Jon currently owns and operates Knox Osteopathic Clinic in Ferntree Gully, Victoria. Jon has worked as an osteopath continually for 40 years now, having graduated in 1983 from the British School of Osteopathy in London. He spent his first few years working in a busy practice in southern England before emigrating to Australia in 1986. In 1988, Jon started his own practice in Ferntree Gully, which he has run as the principal ever since. He's also increased his involvement in teaching at that same time with an emphasis on clinical education. In 1995, Jon moved to Victoria University, where a new osteopathic graduate program had just started. He has taught there since this time and now spends one full day per week at the university, and I think he's going back to teach anatomy there in the near future. Jon not only works supervising the students in clinic as a clinical tutor, but also lectures in a number of subjects, including osteopathic care during pregnancy and management of older patients. Besides his interests in education, Jon is a keen cyclist, both road and mountain biking, as well as an avid dancer, from what I understand. Jon, welcome to the show. I know that you've been able to mentor many osteopaths in your time here in Australia, and you came highly recommended by a lot of people, especially the ones I've talked to down in Victoria. You've been able to influence them, and every time I spoke to them, they say, you've got to talk to Jon Pitcher. You've got to talk to Jon Pitcher. So here I am talking to Jon Pitcher. So great to have you on, mate. Thank you for taking the time.
Thank you. Thank you very much. Thank you. Yeah.
So look, I'll get into the first question and kind of kick things off. I just want to get a bit of backstory about you. I want to understand your background. So tell us a bit about you kind of growing up, and then what led you to osteopathy.
Oh, well, I'll cut a long story short. I grew up in a pretty conservative English background, English private boys' school to the age of about 17. Then I left, went to a TAFE college, went to a very left-leaning TAFE college in the early mid-1970s. It was a bit of a different education system from the private school. But taught me a lot about life and met a lot of different people. I didn't know what I wanted to do when I left school, when I finished, and there weren't many things sort of open to us in those days. You know, you could go up into the city and go into insurance, you could go into banking. There are a lot of boys in my situation that were heading off into the services in the army. I didn't fancy that, but I did a few months' work in a spinal injuries unit in the National Spinal Injuries Centre in England. And I thought, well, maybe I'll go and do nursing for 3 years, try and train as a nurse for 3 years. It's very unusual for a man in those days to go and do nursing. It's very, very strange thing to do, but I know there are a lot more male nurses than doing nursing these days. But I was just very aware of the fact that I had absolutely no life experience. And really, I needed to get out and leave home, go and do something where, and it was good. I mean, I saw some pretty extraordinary things when I was nursing, some pretty tragic things, but it certainly was a good education for life, and I think a very good start for osteopathy. Why did I do osteopathy? Well, I didn't have the right qualifications to get into medicine or physio or those sort of things which I was looking at. I did nursing 3 years, finished the course, decided that it wasn't for me, definitely. Went back to evening class, redid what you see as school certificate, they're called A-levels in England, trying to look at what I was going to do, and I came across in a book on careers in alternatives to medicine, I came across osteopathy. Read about it, when I spoke to an osteopath, thought this sounds pretty good. Applied to the BSO, was amazed to find at very short notice they took me in. And so there, I started. I went down to the BSO, not really knowing quite what I was letting myself in for, or what osteopathy is really all about, and not quite sure what I was expecting. But
Let me interject there
yeah,
for a second and ask you some
yeah,
questions around that. And that story of yours mirrors my own story. I didn't really know what I was doing when I was, I was straight out of high school into it. I didn't really know what to expect. So, mate, what hooked you? Like, when you went and sat down into your first class of osteopathy, who was the person that kind of started to say, this is what osteopathy is, these are the principles, this is how we treat, tell us about that experience. What really hooked you? Like, were you hooked straight away? And who were the people that really influenced you early on?
I think that's an interesting thought, isn't it? I mean, there were a few lecturers there. I mean, there were some who weren't very good. Oddly enough, one of the people who really I just absolutely adored was our anatomy professor, Professor R.W. Haynes. Now, he was in his he seemed very old at the time. He was in his maybe 70 or early 70s. I mean, he's only 4 years older than I am now. So he's sort of, you look at it and think he's Cinderella man. But he's got a lot of references in Gray's, for instance. He was he's just a very gifted teacher and a fantastic knowledge. And I love the way when he taught with a lot of clinical relevance to it. He'd teach anatomy, but say, he'd tell us stories about things he'd seen as a young doctor, and the relevance of a lot of the stuff we're looking at. And I think there were other people as well. I had a very good clinical teacher, I remember, who I had for 2 years, the third and fourth years there, called Fiona Walsh, who was she worked with a lot of ballet companies and was very good. But I think there were a lot of, and always you meet a mix of people. Some people you like, some people you don't like. But I think there was we learned under somebody called Laurie Hartman, who was sort of the great H-fillet guru, taught us all H-fillet. But yeah,
how long did it take you to get hooked? Like how were you? Did it take you long to kind of go? Oh, this is for me. I'm all in.
Yeah, I think it was. I think it was 2 or 3 years into practice before I really started to relax into the whole thing. I think it took me a while. When I first got into practice, there was a guy I worked with who was quite inspirational. He was probably one of the most gifted practitioners I've come across. He was an absolute pig of a man to work for. As unfortunately, but one of the reasons I left the UK, I suspect, at the end, was to try and get away from that. Right. But there was another guy working there as well. They'd been in partnership and had broken up, and there was a lot of ill feeling in the practice. It wasn't a happy practice to work in. But both of them were very gifted practitioners in their own right. The older one worked mainly with babies and treating babies and children. But they were both very inspirational. They taught me how to be an osteopath, really. Then I came out to Australia and I worked with a guy called Philip Tian. And I think Philip Tian taught me how to practice. He was another very gifted man who taught me really how to practice, I think.
What do you mean by that? Explain that to us. Taught you how to practice.
The ones in England really didn't run a very good practice, weren't very good businessmen, weren't very good at managing things. Phil taught me how to actually better manage patients and manage the sort of issues that come up with practice and how to actually run a practice. I think he was a very different character. Yeah.
So it was more to do with the operational side of things rather than just treatment.
Right, yeah, treatment as well, managing patients as well. He would manage patients as well. But he was just a very interesting man to mentor, really.
Right,
yeah.
And he was involved in education here as well.
He was very involved in education and in the registration board as well. Yeah, He was very involved. We used to call him Mr. Osteopathy.
Right.
Very clever.
In terms of your particular clinical experience, tell us about your formative years as a clinician. Tell us about those first 10 years, 15 years of you as a clinician. Where did you kind of formulate your thought process? How did you formulate it? And what kind of patients were you seeing? And did you find yourself moving into a direction of treatment in terms of technique or in terms of actual conditions that you saw or you enjoyed seeing?
I think it was general practice. I don't think we actually specified. I've never been a great one for sports injury. I got involved for a while with not by choice, I have to admit, but because they found me with a group of dancers who had a dance company, and I used to go off on Friday mornings and treat a dance company in Collingwood for a while. That was something. But I went on and what did I do? I think just general practice, Sammy. I don't know that.
That must have been awful for you, John, to be around a whole bunch of women who are fighting fit.
Well, there were a few men in there as well.
Yeah, and men. Yeah.
Well, fighting fit's a very interesting one. I mean, the classic dancer, particularly in those days, you'd rock up to the Collingwood studios where they were working, and they'd all be standing out drinking black coffee and smoking cigarettes.
Yeah, right.
So typical dancers. The idea that they should eat anything before they actually went out and started training was a bit unheard of.
Yeah, they were very lean. Well, they still are very lean.
They are very. That's right. Yeah, and God forbid they should put any weight on.
That's always a problem when you treat with dancers, trying to get them some weight on.
Yeah, that's right. And injuries. I mean, they dance with stress fractures in their feet and all sorts of things, and stuff you say you can't go on. Oh, I'll be fine. Don't.
Well, I found one of the things with dancers, and especially the coaches, is that the idea of dancing. It's almost the brutality of it is almost on the same level as, say, rugby league or something like that.
Oh,
or
yeah,
AFL.
yeah.
Because the coaches are saying, listen, I need you to push your joint past where it should go.
Yeah, that's right. Yes, that's right. Yeah,
and the dancer just goes, I'll do that. And I think that's just for looking at dysfunctional joints and ligaments and all that kind of, and tissues and fascia and. The trauma, like, so just repetitive trauma over time. It's they're really banged up, those dancers,
and they dance with pretty amazing injuries as well. I mean, I had one dancer who came in and she said, "Oh, I have a problem with this right hamstring." And she showed me the X-ray, and she had completely avulsed the origin of the hamstring off the ischium. And she showed me what she did with it. She brought the leg right up, almost over her head, and I said, "Well, what's wrong with that?" She said, "Well, the left one does this," and the head came right up over her head. So she was about 10 degrees off the left one, but she thought that was a major problem. And yet it was mobility that most normal people can go at about 90 degrees if they're lucky. She was getting to 180 on the left side, but she was stopping short about 170 on the right because of this major trauma, and caused a lot of pain. But she just danced on with it because that's
they just get on with it.
Yeah,
they just get on with it. So you've earned a reputation especially amongst the people that have recommended that I speak to you, as being somebody who's quite very competent in HVLA and that in that area of joint mobilization. What kind of led you to focus in on that modality in terms
that was very much, I think that was, if you look at all the old BSO graduates from the time, we very much were soft tissue articulation HVLA. You've got to bear in mind that we were using some muscle energy, but muscle energy had sort of come over from the States at about that time, so early 80s, but maybe 1980 or a bit in early 80s, we were starting to introduce muscle energy, but not so much in the diagnostic process, but more in the actual treatment process, combining it with HVLA and soft tissue and articulation and things. Cranial was creeping a bit. Cranial never sat well with me. I'm not going to have a bash on cranial. I practiced it at various times. I did a course in England. I had to do a course when I first started in cranial. I've never really seen any benefits from doing cranial. I've never felt any benefits of doing cranial. I don't really see how the whole thing works. So I moved fairly quickly away from the indirect approach.
Yeah, right. It's fairly odd because, well, not, it's not odd. It's just, it is what it is. But I tend to find that the practitioners I'm talking to with lots of experience tend to move more indirectly as they get on, and it's just you're one of the first people I've spoken to that has kind of like moved. Said no.
I've tried it. Believe me, I tried cranial. I tried cranial. But I think that I fell asleep one afternoon in the middle of a treatment, and I finally decided, and the patient had no idea, and got up and paid for it.
Oh,
And I went home that night and said to my wife, said, look, I
can't do
I
this.
cannot do this anymore. I just can't do this anymore. I've just treated somebody while I slept soundly in the chair behind them with my hands on their head.
Yeah.
And then I had to try and convince the patient I'd done something at the end of it. Now, there's a lot of cranial practitioners out there who are going to be shaking their heads and sort of saying, oh my God, he's got no idea what he's talking about. And, look, I've discussed this at length with many people, many academics, many people at university, many cranial practitioners, and I cannot see how you can be doing what we had to mark. I think I had to mark a master's for our research study. Now I was a co-supervisor with it, and we had a very good student. He was doing a study on treating children with respiratory problems using cranial. And he did a very good workup on all these children, very good case histories on them. He did a very good respiratory examination and did peak flows and all sorts of things. We then had a group of experienced cranial practitioners come in to treat them. Not one of them actually treated on any sort of way based on the findings that the student came up with, the physical findings to come up with. There were odd claims made in the thing. I mean, one of the cranial practitioners made a claim that they were remodeling the foramen magnum. Now, even if he could do that, I think it would be an extraordinarily dangerous thing to do. I had a patient who had a malformed foramen magnum and had to go and eventually have surgery done. I mean, but, the surgery was through the mouth, through the neck. It was incredibly difficult procedure where they just took a tiny bit of foramen magnum away. So this concept of I don't know what this cranial practitioner thought was going on, but somehow in his or her mind, they are remodeling the foramen magnum. But I don't know what this model is that they've got in their mind or what the hell they're doing. It's a piece of structure that really you can't remodel from the outside. And secondly, you shouldn't be doing it. I mean, it's a very essential piece of anatomy that has very fine parameters to it. And there were a lot of this stuff went into this paper, and I really looked at it and I thought, look, we really got to get a grip on the reality of this situation and what is going on. So no, I definitely treat it in a very structural way. I mean, I don't like to think of myself as a structural cranial osteopath. I'd like to say I'm an osteopath.
Yeah.
I use the techniques I was taught. I've honed them over the years. Patients find them good. I mean, I think if you're treating necks, traction is one of the most wonderful things you can possibly do to a patient with a stiff neck. So many
Definitely.
patients, particularly older patients, good cervical traction is just a beautiful thing to have done to you.
Yeah, I think also when you've used those kind of tried and successful techniques and you've got them down pat really well, and they work for you, you just keep building on them. You keep using them.
Yeah, that's right.
So I have to totally agree with you on everything you just said in the last 5 minutes. I haven't really gone down the great cranial path, so I can't speak with any authority on it. But to those claims, I guess, of changing anatomy in that way, they're from. I consider myself an outsider for cranial. I don't practice it. I don't use it. I don't know enough about it. But to hear those claims, they're a bit hard to kind of swallow. But I guess that community, that cranial community, has to figure that out for themselves and how they're willing to, how they're willing to define their own speech, I guess.
Yeah.
There
is a slight. I do one thing. There is one thing about amongst the osteopaths that does irritate me. There's always this faint sort of feeling I get with people who practice cranially that somehow they are in a slightly higher level of being compared to the sort of the structural people.
The Jedi Masters.
I always find that's a slightly offensive thing, really, to do. Somehow the people introduce themselves. I'm a cranial practitioner.
One of my previous guests mentioned the same thing as you. She said, well, it's not better. It's not like it's an advanced technique, but they do. Yeah, it is kind of, flouted as something that requires extra palpatory.
I'm gonna say something interesting about it. I was with I used to work on the registration board, and I was with another English osteopath called Brian Nichols, Now, Brian Nichols is a very well-known osteopath. He taught at VU for many years, and he's been practicing. He's now retired. And we were at a board dinner, and we were talking to one of the board lawyers, and she was chatting away, and she was saying, "Oh, I went down, I had my cranial treatment today. I had an hour with a cranial practitioner. I feel absolutely fantastic afterwards. You know, I don't worry about cranial, but I just feel wonderful." And Brian, quite independent of me, said, "Well, it's just a very deep relaxation technique." And I said, "Well, I think you've got a point, Brian." She said, "Oh, no, they're doing something else." We said, "Well, no, I don't think so." I mean, she was a very manic character. We said, "Well, how often do you actually lie down on your own, in a room or with somebody else, and actually take an hour to just do absolutely nothing at all?" She said, "Well, yeah, not very often." And I said, "So somebody's there, they hold it." The other thing, I trained with a psychiatrist in London in the BSO. He came into the last 2 years. And he came in one day. We had a very anxious and rather depressed patient, and I asked him to come in and talk to the patient and give us some ideas. And I was doing a 2-man cranial technique on this patient as a fourth year student. So I was holding the head, and we had a friend of mine with his hand under her sacrum and on top of her pelvis. And the psychiatrist came in and stood there in the room watching us, and I'm talking very quietly to her and things. And he just gave me a thumbs up and walked out. And I said, "Hang on." I went out after and said to him, "You're the psychiatrist, you're supposed to come in and help me." He said, "That's fantastic." He said, "That's wonderful. I mean, what do you do with the baby when it's in pain, when it's been suffering? You pick it up and you hold it and you talk to it quietly." He said, "That's what you're doing with her. She's having a wonderful time. She's being comforted by 2 caring people." He said, "I don't care whether you're manipulating her skull bones or anything." He said, "You're helping her." But I mean, maybe that's, yeah.
Well, I guess if it helps, if the mechanism helps, sometimes I say to patients, if a rain dance helps you, go outside and start having turn on the music.
That's right. But I know a lot of, if anybody who practices cranially is listening to this, they're going to be hating me right now.
Well, look, it's, I'll have to have one of them on, and I guess we'll ask them the question.
So,
this is the point.
Did you hear Jon Pitcher? Did you hear Jon Pitcher?
To kind of go deep diving into certain topics.
Yeah.
Look, I want to also ask you about the soft tissue work that you do.
Yes.
Is it that, were you taught everything that you kind of developed? I know you've developed a lot over the years, but your base of soft tissue, was that just taught to you at the BSO? Or
yes, it was.
Did you have to go and search for some other?
No. It taught me at the BSO, and it was taught by somebody. We had a wonderful guy who came and did a lot of soft tissue teaching called Jon Meffin. Now, Jon Meffin was probably my age now. I seemed very old again at the time. When you're 20, 21, 22, somebody who's in their mid-late 60s seems like very, very old. Jon Meffin had these long fingers and great big hands, and he'd been over in America and studied rolfing and all sorts of things. But he'd actually learnt, as far as I remember, from the people like Little John and people like that who'd come over to the original osteopaths that came to the UK and set up the sort of schools and things there. So I suppose what I do is you could trace it back now maybe 80 years or so, or more, maybe back 100 years. But traditionally, osteopathic soft tissue work, and I'm sure if Gary Fryer comes on, you can ask him about this. Traditionally, it wasn't done with lubricants. You don't treat lubricants. You treat through the skin. It's like tuning through a radio. I always tell students, it's like tuning through a radio. You don't want the skin. You don't want it. You want to bypass the skin. You come through the skin, find the tissue you're after, and then you stretch that tissue. And all techniques are broken down into aim of the technique, applicator contact, force velocity, and amplitude. And that applies to HVLA. It applies to soft tissue work as well. Yeah. All technique is broken down. And that is the way soft tissue broken down. What are you after? So you don't if you actually, one of the things I love doing with students is showing them the difference between using lubricants and non-lubricants. I get them to do some side-lying soft tissue work. So that sort of you can see my hand somewhere in front here. I don't know. There we are. This sort of drawing up on the skin up and drawing up on the erector spinae away from the spine's processes. But not running over the muscle, but pulling the muscle and stretching the fascia and soft tissues out. I get them to do that without lubricant. Then I say, now put a bit of that awful Sorbolene on and see what happens. And they can't do it. You can't do it. It's too hard in your hands. You can't grip.
Yeah.
You slide all over the place and you can't do it. And they all go, oh, you've got a point. Yeah, you can't. So I think that's been lost. I think traditional soft tissue work is not being taught and it's been lost completely.
Yeah, we'll get to that.
Yeah.
I will get to that and discuss that with you. But you're totally right. I banned lubricants from my clinic about 10 years ago. I had some, because I've got students that work there as well, and I've got some massage therapists, and I'm trying to teach them how to, even the massage therapists, I try and teach them how to treat and not how to massage, if that makes sense.
Yeah, that's right. Yes, that's right.
And I was saying, look, if you're just going to lay them down and rub oil all over them, they can go to a spa house and get that. They're there to get a treatment, and you need to understand what's under your hands, what's under your forearms, and what's under your thenas, and really start to push through skin, start to push through layers, and understand feedback. And you're not going to do that if you've got a whole bunch of oil under your hands.
That's right.
Totally agree with you on that.
Teaching technique is very difficult. I mean, it's very hard in a situation where you've got 60 students and you've got, say, 3 or 4 tutors there trying to teach, because you really can't get around. I've, for some years now, run small group tutorials in the practice where I get 6 students. We get 3 tables in the waiting room, up 6 students, and I can really focus on, I've got 3 students doing it at any one time, and I can really focus on taking them through techniques, whether it be soft tissue technique or whether it be advanced HVLA type approach, particularly peripheral HVLA. Peripheral HVLA, really the students are coming out without doing, and I'm sorry, Gary Fry's going to be very offended by this when he hears this, but that they're not doing the amount of peripheral HVLA that we learned from people like Laurie Hartman. And I think it's a pity, because if we don't actually keep those techniques up and running and keep people abreast of that, all the techniques you can use. I mean, there's 9 ways of manipulating a totocrural joint that I know of, and there's probably more, But if you just teach students one way, then you're not really giving them the full range. And there's different ways of doing it. Do you want to shear it PA? Do you want to shear it AP? Do you want to traction it? There's a lot of ways of doing things.
Look, in practice, you probably only use, in practice, 90% of the time, you probably only, if you know 9 ways of doing something, 90% of the time you're probably only going to use 3 of them. But it's best that you have the whole 9 in your arsenal. That's you will get that one patient that will need something that's out of the box, and you'll make it. You'll present yourself as a point of difference if you have that technique. Yeah. I want to discuss with you, John, a little bit about osteopathic principles and philosophy, and I guess you'd be a good person to talk to because you've been around for a while. How do you view those 4 principles of osteopathy? Those the structure, function, body as a unit, self-regulation, self-healing.
That's right. Self-healing is an interesting one.
Let's go through. Let's start there. Let's start with the body.
Self-healing
has a capacity for self-regulation, healing, and maintenance.
The one thing that's dawned on me over the years more and more is I seem to spend most of my time actually, you're helping the body to heal, obviously, but you're undoing the body's response to injury. The sprained ankle is a classic example, we always talk about. So somebody rolls their ankle and they strain or tear the anterolateral ligaments there, and you get swelling. Various things happen at that point that are totally counterintuitive to the recovery. First of all, you get swelling, you get further hypoxic injury, all sorts of things going on. You get destabilize the joint, all the muscles that you need get turned off. The actual proprioception gets lessened. We know that all sorts of things like balance and coordination get affected. So what do we do? We undo all that. We try and reduce the swelling. The body's swelling. The body's producing swelling. We try and reduce the swelling. We try and mobilize this. The joints get stiff in the rest of the foot. We try and mobilize the rest of the foot to try and stop this constant loading. We support the injured ligament. We then start to get them doing exercises to try and strengthen up the muscles that should be strong anyway. Why doesn't the body do this in the first place? I've never had an answer to that.
Sorry, explain that question again. Why does the body respond in that way?
Why does the body respond? Why does the body turn? Why do the perineal muscles get deactivated? Why do they stop? So why don't we get increased activity in the perineal muscles? I mean, really, if you think about it logically, what we should be doing is not having this swelling and hypoxic injury. It lets a lot of inflammatory cells and things get to the area and maybe starts the healing process. But we shouldn't be losing. The body shouldn't be losing coordination and proprioception. It shouldn't be getting weak in the perineal muscles. It should be almost enhancing the activity of the perineal muscles to support what the ligaments now not doing. But that's not what happens. The same thing with backs. Somebody hurts their low back. I've just treated my son today. I'm on his computer, and he's got the typical. He came in to see me. His friend said, "Dad, I've hurt my back. I'm going overseas in a week's time." And he came in. He's 32. He's got the typical, antalgic posture, pain with flexion. He bends. He's got pain on the right hand side. He flexes he side bends and flexes the right hand side. As he kind of extension eases it a bit, various things. So typical sort of thing we might think of as, we might call a disc. We don't really know what's going on there, but we have perhaps a model of there being a disc injury in the back, a little fissure in the disc or a little tear in the back of the disc or something going on there. Okay. But he's got spasm all up his back. His back has gone stiff. He's not activating his glutes anymore. So he's starting to bend through the back. He's not bending through the hips anymore. So what do? I treat him by mobilizing the thoracolumbar area. It's gone really stiff. I manipulated his mid-thoracic spine. We did some traction down at the bottom to try and reduce all the inflammation that's built up there and various things. I'm undoing the body's response to injury, and I'm getting him to start to activate his glutes a bit and try and activate his glutes as he bend. Why am I having to undo the body's response to injury every time somebody comes in with an injury?
Yeah, well, I mean, they're guarding mechanisms.
They are guiding mechanisms, but
they're guiding mechanisms. So the body's obviously evolved. I mean, in the last 100 years, we've probably enjoyed a great lifestyle.
Yes,
right?
Yes.
But previous to that, life was a lot tougher, and I guess our bodies were probably a lot tougher too. Like your great grandfather ploughed the fields and did some heavy work. And if he hurt his back, it would take a lot of stress to be able to do that.
Yeah.
And so I figure that if people had injuries in those days, they were pretty decent injuries that required some kind of immobilization or some kind of rest for recovery.
I guess so.
I don't know if we've lost that yet. 100 years is a long time in evolution.
I don't think we have, because I think if you look at history, there are many instances of people, going back into medieval periods of documented cases of people with very similar injuries to the sort of injuries we're seeing now, with laid up with bad backs and all sorts of things.
And I mean, osteopathy probably is not a new thing either. Like, I mean, surely somebody back in the Byzantine Empire thought, you know what, let's just roll him over.
Well, there's a very interesting book, which has long gone out of print, and I wish I could get a copy of it, written by somebody called James Syriax. Now, anybody who is my age and is listening to this will instantly recognise the name James Syriax. He wrote a couple of books. He was a doctor in England, specialist in manual medicine, and he wrote 2 volumes. One was called Manual Medicine, Principles of Manual Medicine, which is a wonderful book. Lots of anecdotal stuff in it. And he wrote the textbook of manual medicine, which was basically before we had a lot of the manipulation books like Hartman and people started producing books. He was one of the only books out there, the Syriax book of manipulation. He's got lots and lots of what we consider to be the osteopathic manipulation or but he's got those listed in his book. He shows how to manipulate spines, and he's showing how to manipulate radial heads and things like that. But he also wrote a book, and I think it was published back in the late 50s or early 60s, called History of Manipulation. And I saw a copy once and remember looking through it and reading bits of it. Must have been back in the early 80s when I was a student. I have been trying to get hold of a copy ever since, but he had some wonderful photos in there. And one was of, I think it's a statue in Thailand from 2,000 years ago.
Wow.
And it's two people. One is lying flat, and they thought it was two wrestlers initially, but until they realised that the person lying down has got their hands folded and their head down like this, looking very comfortable. The person who is standing or is actually doing a quads or femoral nerve stretch. So they're doing a hip flexor stretch, if you like, or quad stretch. And he had various examples of this going back through early Islamic art of people doing manipulation. Descriptions of people back in Greek and Roman times doing virtually the same stuff as we do now.
It can't be new. I mean,
and if you
people
look at
have suffered from back pain and
that's right,
all this kind of stuff, and someone must have figured it out and said, you know what, let's roll them over and see what moves and see how we can help them. I'm sure it's not a new idea. I mean, AT still probably just formalized it and put it together. And
he put together. I mean, osteopathy is not about a whole lot of. He didn't suddenly invent all these manual therapy techniques; that they were there already.
Yeah.
He was a bone. The bone setters were around in the States, and he learnt off the bone setters. The bone setters go back into medieval England and probably the Dark Age. We have lovely stories about the barber surgeons who went around in their caravans from village to village, and they were, and amongst apart from lopping off infected fingers and stitching people up and doing all sorts of things, they would manipulate people's necks.
Yeah, right.
And presumably once in a while they caused a stroke and got chucked in the pond and drowned or
deregistered.
That's right. Yes, it's right. Rather more severe punishment than deregistration.
Look, not to get off track about the healing and the regulation. I mean, we've discussed that how you're trying to really undo a lot of the body's responses.
Yeah.
I think a lot of those responses are guarding mechanisms that have probably evolved over the years that may change in the future. Who knows with technology and where things go there.
I suspect the guarding mechanisms go back a lot further. I think probably a lot of that stuff goes back to right back on the savannah. When we first came out of Africa and places and merged as a species, and maybe even earlier than that.
One thing I want to get your opinion on is the role of maintenance. I know that's in our principles. The body's capable of self-regulation, healing, and maintenance, and so. Yes. There's a debate within the profession about maintenance or maintenance treatment, like trying to preempt and prevent. So when a patient comes to see you, John, and you look at them and you go, you know what, I'm not really happy with this kind of strain pattern or loading pattern that I'm seeing in front of me here. I think if we can unwind this, we can probably prevent some things down the track. Has that been your experience, or is that something that you steer away from? Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you, and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
No, I think it's something that I do a lot of. I think it's right. People come in for, I don't know, I never liked the word maintenance treatment. There was a big thing about maintenance treatment the physios did back in the 90s. There was a whole paper written on the concept of maintenance treatment. And
well, let's not call it maintenance, maybe preemptive treatment.
Yeah, preemptive treatment. I think a lot of people come in for preemptive treatment. They start to notice themselves that they start to pick up the signs of when they get in trouble, or they come in before it starts.
How accurate do you think you are, John? Like when you see a patient, you kind of look at a certain pattern developing there. How accurate do you think you are in terms of, and in terms of when you see these patients and you do these preemptive treatments, you find that they just avoid acute injury?
That's a very good question. The answer is no, they don't entirely. Having said that, I've got a lady who I saw on Monday. Yes, Monday was yesterday. Who we recognise if she doesn't get the stiffness around her thoracolumbar junction dealt with about every 6 weeks, if she skips a treatment or misses it and goes 3 months, the next thing we do is we often see her with acute pain. Now, I've been seeing her for 15 years. So we've had a long time to build up this sort of pattern. There was just recently I went overseas and I didn't see her for longer than usual. Next thing is she's on the phone saying, I need to come and see you, I've hurt my back. And she said, I knew what it was. I skipped the treatment last time. We missed the treatment. Then you went overseas. I wasn't able to get in. And I could feel myself getting stiff, And now people might say, well, that's obviously psychosomatic. It's obviously just she's brought on herself. I don't think it is at all. I think that's I think she knows she's getting stiff. And when you examine her, you say, just bend forward, bend back. And you can look at her and say, can you feel how stiff that is as you bend back? And they say, oh, gosh, yeah, that's, I didn't realize how stiff that had got. And you treat them. Show them how stiff they are, you treat them, you stand them up afterwards. And after examining people afterwards and demonstrating to them that they are actually improved is a big part of the whole treatment process.
Well, that's psychosomatic too, but that's a good psychosomatic.
It's a good psychosomatic. I mean, they walk out, they feel better. They feel like, I think it's the thing, people walk out, they feel like they've actually been treated. But she stands up and she says, well, actually, no, that is, and you can see it, you observe it yourself, and the patient experiences it themselves. Now, okay, there's, I don't know how you'd ever prove that. It's... look, you're not going to get a whole bunch of people in a randomised controlled trial to do that. But I think longitudinal studies, I mean, if you followed this patient around for the 15 years that you've seen her, you could track that. And I think that might be something that we can do in the near future with AI, with artificial intelligence, that they wibble their way through your notes, John, your treatment notes, and they figure out what you've done and can track some things. So hopefully that could be something we could look to in the future. I want to ask you about the principle of the fourth principle, the one that people think that osteopaths' rational treatment is based on the first three principles. Why do you think that has to be there? Now I've said it again. So this is, you're thinking about that treatment is based on the first three principles. Yeah,
well, the fourth principle is that rational treatment is based on the first three principles of body unity, structure, function, and self-regulation. It seems like quite an obvious thing to state that rational treatment should be based on the first three principles.
Yeah.
Why would that?
I think
require to be there?
You're back to your diagnosis again, aren't you? It's all very well identifying what's going on. So you've looked at your diagnosis and we've made a stab at what might be causing the symptoms, but then you've looked at what has led the patient to that point, where has been the breakdown in the homeostasis. that's allowed them to have developed this problem. And it may well be if they perhaps suffered some major trauma, if they've been sitting in a car and they've had their head turned to the right and somebody slammed into them from behind, and they've suffered major injury to the facet joints in their neck from the hyperextension rotation movement, then that's a different thing completely. But if it's something that is they've suffered some sort of postural loading problem from sitting too much or not doing enough exercise, or a whole build-up of things, poor sleeping, you start looking at all the contributory factors that has led to a breakdown in the homeostasis that allows the body to maintain a healthy environment or a healthy state. And obviously then your treatment is based on those findings. So it's to be back to predisposing maintaining factors again, which comes.
No, I think also that AT still was, as much as it was kind of, he gets a little bit of criticism these days, but he was a bit ahead of his time, because I think he knew that there were certain forces coming, especially that him being an MD that became an osteopath. He's basically telling us that if you want to be an osteopath, you need to think like an osteopath. Not so much. Yeah. It's not so much about what you do; it's more about how you think. And I think that's really ahead of its time, because most people would think in the moment that if he's a bone setter, if he's observed a lot of bone setters and what they do, he would probably think, well, this is how osteopathy should be. But I think he's looked into the future and he said, look, there's going to be a whole bunch of techniques coming down the track, but it's really the way you think that defines you as an osteopath, and that's why rational treatment should be based on the first three principles.
Yeah, and, absolutely right. Yeah.
And as a profession, we haven't always had registration. That registration paper doesn't really mean that you're an osteopath. It just means that the government recognises you as an osteopath.
You recognise your qualification.
Yeah, that's right. But if you want to be an osteopath, you need to base your treatment, your rational treatment, on the first three principles of osteopathy.
That's right. Yeah.
So that's my take on it, and I think it's that fourth principle is really ahead of its time. Okay, so look, I want to move on and ask you about your experience with both Victoria University and RMIT. I think I think you started at RMIT. Is that correct?
I did. Yes, I did.
Tell us about your journey in education. Tell us about the kind of the history and the timeline of it, and then I'll ask you some questions around that experience.
If I remember back that far, when I came out to Australia, we came to a situation where I forget how many osteopaths there were in Melbourne at the time, but there was something. It was about 10 or 12 in Melbourne at the time. We used to. I remember when I first arrived in England, you had the General Council Register of Osteopaths, and it was a hallowed group of people who you had to rise through the ranks and of seniority to even be considered to sit at the board table with the General Council Register. So I arrive here and start working for Phil Tian, and somewhere in about my second week here, Phil says, "Oh, there's an AOA meeting on this evening. Do you want to come?" And I said, "Me?" He said, "Yeah, more the merrier. We're just," and I turned up to this meeting, and we're all just meeting around Jury Benish's, who was one of the great legendary osteopaths at the time. Jury Benish's treatment table in his treatment room, and there was Kevin Janine Sturgis, and there was a guy called Simon Clement, and there was David Whitaker, and all these sort of amazing people, and Phil Tian, of course. And we sat round and we talked. They talked about, what are we going to do with this? We got this from the government, and this happening and that happening, and and it was there were just a bunch of really dedicated people working for no money. I mean, nobody's earning any money from this stuff. Doing extraordinary things to keep osteopathy running, and get this course all together. They just started the course at Phillip Institute, and we had people like Gary Fryer, people like Glenn Bales, Ray Myers came in. He was the third year to go through, I think, so he was a bit later, and all these people went on to do universities. But basically, they sort of said, what are you going to teach? And I said, I'm two and a half, 3 years out. I can't teach anything. I mean, the teachers are all people with experience. They said, well, tough luck. We need somebody to go and teach. So you can go and teach history and principles. And so I went out and started teaching history and principles. Terrifying thing, teaching. Because I walked into a room and expecting to find 25 osteopaths there, students there, and to find confronted by 75 chiropractic students as well, And I remember rattling through all my material in about 25, 30 minutes, and then sort of thinking, what the hell am I going to do for the other half hour? I had an hour for them, I mean, with experience, you'd know what to do, but you'd start chatting about some cases, and students love to talk about cases.
Yeah.
Always, anybody's teaching out there, ever get stuck, just talk about some difficult cases and things you've made a mess of. Oh, students love it. Things you found you got right, and But then we started the teaching clinic out there, and again, same thing. They said, we need somebody to go out and start working in the teaching clinic. So myself and Simon Clement and I think David Whitaker, agreed to go out there and start the teaching clinic, which meant actually going out and seeing patients. So we waited, and then finally I had a phone call one Wednesday. I think I was going out on a Thursday morning, one Wednesday, from somebody at the uni saying, there's a patient at the teaching clinic. And I said, okay. So I've got in my little old Renault at the time with no air conditioning and drove from Ferntree Gully, Upper Ferntree Gully, out to Bandura. Saw one patient in the teaching clinic, but that was ground zero for the teaching clinic, and nobody got paid for it. I think what people don't realise, the students don't realise these days, is that the work that went into, and it's not just me, I'm not blowing my own trumpet here, I'm talking about the people who, Phil Tian, the extraordinary amount of work that guy did, getting that course up and running.
Well, it's passion. That's got to be just
and it is,
on
and I
passion.
think this is what I think we don't really hear about these days. The sort of history of what happened in those early years, and just people don't realise just how much was put in by so few that led to the benefit.
Do you
of
think
so
that?
many.
Do you think that we should be asking these people what they like for their input into how the profession should move along in the future?
I think we've probably all got to a stage where we realise that it's the role of the younger ones coming up now.
I understand that. I think it is the role of the younger ones, but it's always good to ask.
Well, I think without doubt, again, Philip Tian would be a great person to talk to.
Because you guys have been through much tougher challenges than what we're going through now. I mean, to have no government recognition.
Yeah.
No, literally, like it's a blank canvas. You're starting a profession from the ground up.
Yeah, that's right. Yeah,
and a lot of the things that we take for granted now, it was due to the people that fought.
I mean, we had to fight very hard to keep that course running at Philip Institute, the course that is now running at RMIT. We had to fight very hard to keep the course running. It was touch and go whether we'd actually have. We almost had a lot of osteopathic subjects being taught by chiropractors at the time.
And I think that was the first course of its kind anywhere in the world. First tertiary education course.
It was the first
that was teaching osteopathy
outside America. Outside America, yeah.
Yeah, right.
Yeah. It was pretty amazing, and it was a great course. Actually, it was a very good course because it was based a lot on the chiropractic, and we had a lot of chiropractic lecturers. So they had some very. I mean, if you get any of the graduates from that time up and talk to them, they'll tell you about some pretty terrifying lectures the chiropractors had. I had a lady called Jenny Jameson, she was a medical doctor, and taught sort of pathology and clinical methods and various things. She was a pretty frightening person to be a student in front of. She's, but so the standard was very high indeed, really.
And tell us about your time at Victoria University. How did you go about moving there?
I left. I actually got sacked from RMIT. That's a long story. But I rocked the boat a bit too much at one point, and
that could be another podcast.
So that's another whole story. There was a lot of ill feeling there. But so in '91, I actually left RMIT or what Philip Institute became RMIT. I think about somewhere around 94, 95, we started VU, and they approached me and said, would I go back and do some teaching? And again, we started back in the clinic with the first group of students to come through, and that was a pretty exciting time. Peter Gibbons, he was an osteopath and a doctor. He was head of the program. I got on extremely well with Peter Gibbons. I think he's a fantastic guy, and he was an excellent start to the whole thing. And but again, I worked mainly in the clinic, did some teaching, sort of basic case study teaching with third years. A lot of I think I love small group tutorial teaching is my favourite thing. I love doing case presentations and using cases for any number of things, that, from learning how to take a history to learning how to examine a patient, learning how to make a diagnosis, to actually constructing treatment plans, to all sorts of things. You can use case histories in. When I always bring cases from practice. The great thing about cases from practice is they have natural inconsistencies in them. If you construct a case history, it looks too perfect. But if you bring one from practice, the students will say, well, that doesn't make sense. I say, well, I know it doesn't make sense, but that's the way it was. So I think.
Well, if you look a bit deeper, it will make sense. There'll be a reason.
Right. It does.
That's the cue for you to go a little bit further, right?
Yeah. So that was really where I started, and I've taught at VU for about 25 years, teaching, always clinical teaching. Always working in the clinic, mostly with fourth years or sometimes fifth years, mostly fourth year students. But I also taught. They used to call it the world according to Jon Pitcher. But it was essentially it was a case based common cases, common conditions.
Right.
And I also taught extensively advanced H-fillet, spinal and peripheral H-fillet.
So then, look, compare and contrast the two courses. I'm from Sydney.
Right.
When I was going through university, we really looked up to the RMIT graduates as being real superstars. I mean, our university was really just kickstarting. I was a second year through that cohort, and we would have people coming in from RMIT teaching us that had been out for a few years, 4 or 5 years.
Yeah.
We looked up and we thought, wow, these are some amazing graduates, osteopaths. And so we looked up to that course. VU, I think, was more of we saw it as heading in more of a evidence-based direction at the time. But I'm just talking out of what I saw. You, on the other hand, had first-hand knowledge of both courses.
Yeah.
Compare and contrast those for us. And what were some of the good things?
I don't know that I saw. I don't know. I can comment very much on the RMIT course because I wasn't. After 91, I wasn't really involved much in RMIT. I mean, I dealt with some RMIT graduates at various times. Sorry to cut you off. I have to ask the question now that you brought it up earlier as well. You left RMIT. Was that one of the reasons why you kicked up a stink? Do you think that the course was heading in a direction that you weren't happy with? No, there was we felt there was a threat, and they said, look, this is a very contentious issue, and it's a long time ago, but it could still upset some people. Let's say we felt there was a threat to the actual existence of the course.
Right. Okay.
At that time.
All right. Okay. Moving on. Tell us about Tell us about the courses, the course at Victoria University, and what were some of the good things about that course that you felt they did right, and what do you think they could have done better?
What they could have done better. Well, I think it's a very good course, the VU course. I think both, from what I've seen of graduates coming out these days from both programs, my personal feeling is that they need to have more emphasis on basic technique, soft tissue, articulation, traction, MET, all this stuff. I think there needs to be perhaps less influence on the H-fillet, more influence on the basic technique skills. But that's my personal opinion. Now, a lot of people would disagree with that, and I respect their opinion on that as well. But I feel both courses, what I've seen of graduates coming out, need to go back to more of teaching more extensively the basic technique level.
So do you feel that we discussed earlier about that fourth principle, and that osteopaths really treat based on the osteopathic principles.
Yeah.
Do you feel like that we're graduating osteopaths that do that, or are we graduating people with health science degrees that happen to know a few techniques? I'm asking a very direct question here. Because you've seen things over the years, John. You're not somebody that's just kind of come down the last 10 years. You've experienced osteopathy for 40 years now. How do you feel about that? I mean, this is the future, and these are the people that are coming into practice with you. Tell us some thoughts. Hello, everyone. Just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes, so for more information, please see the show notes. Now, enjoy, and back to the show.
I've with almost all the graduates I've had in recent years, I've had to let's say I haven't so I have to. I had to be very careful. I say I don't want to upset anybody here, but I have taken on one side and given them quite a lot of work on their basic technique skills, particularly soft tissue, a lot of basic articulation, particularly peripheral articulation, a lot of spinal techniques. I think there's look, and maybe people would say, well, that's something that you teach students the basics, and there was a feeling that one time from one of the higher staff higher up in the course that we were teaching too much, particularly in the advanced stage fillet program, that the program students were complaining that they were being taught too much, too many techniques. I don't think we were doing anything more than was done to me when I was a student, and I think it benefited me enormously. I personally think we shouldn't let the tail wag the dog on that situation. We know what they need. I was working with a good guy who's do the co-lecturer with me, teaching advanced stage fillet, and we said we know what they need in practice. We know what's important in practice. We should make the decision about what they get taught. We don't want the students starting to dictate what they should. No,
you can't have the inmates running the asylum.
That's right. Yeah, that's right. Yeah.
Yeah. Okay. And so you find that you're working a lot harder now as a practitioner to bring new graduates up to scratch.
I think it's always mentoring is a funny thing, isn't it? I mean, I don't do a lot of deliberate mentoring of my graduates. I'm there, and I'm happy to have sessions with them and go through techniques with them. Mentoring, graduates have to want to be mentored. And I've certainly had graduates who don't seem to want to be mentored.
Right.
Yeah.
And what kind of questions are they coming to you with? Are there common threads there?
Yeah, common. I think about technique, about managing patients, about one of the biggest problems, of course, is always getting them to rebook a patient.
Right.
To actually trying to get them to actually manage a patient and book them back in again. My wife runs the practice for me, and she's spent years and years, spent the last 35 years in practice watching graduates come in and have this see how you walk out and say see how you go after a new patient walks out with an acute problem or long-term issue, and the graduate says, see how you go, give us a call, and
we've banned that phrase.
We're absolutely we tried to do the same thing with ours and say, don't manage the patient. I prefer you over service.
Yeah.
Let the patient cancel.
Yeah.
Then err on the side of over-servicing, even though because invariably graduates won't be over-servicing.
No, new graduates generally. I mean, even if they do over-service, they won't over-service because
that's right. Yeah,
their application isn't as thorough as what your application.
That's right. Yeah, that's right.
So you're better off. You're better off as a practitioner having to pull them back than trying to push them forward.
That's right. Yeah.
And that applies to technique too. Like if somebody can't get their thrust right, you're better off having somebody that's over thrusting and say pull back a little bit and trying to get someone to
that's right. Forward. It's all about confidence. It's all about confidence in management and things. But it's an interesting one. I mean,
your wife would be should be pulling her hair out listening to that conversation in the hallway.
She does. She often says to me. She often comes and says to me, we've got to do something. They came out and said again, see how you go.
Yeah.
It's just
do your graduates and yourself as well, but do your graduates put them specific, like do you guys use treatment plans? Do you have physical treatment plans that you write up for your patients that they come out, they give to the patient and the patient kind of knows where they're heading with treatment?
I think it's something you discuss with patients. So you always discuss a treatment plan with patients. I don't think we have a written treatment plan as such. No. No, I don't think we do. I mean, maybe some of the practitioners do. They certainly emails patients a lot. I'm probably a bit of a dinosaur. I don't do a lot of emailing of patients. I phone patients and talk to them. I have a interesting idea about exercise that I listened to a very experienced physio. Well, experienced. I mean, he was in his 40s. When I first got out in practice, I went along to a physio conference with Phil Tian, and a very good physio was talking about rehab exercises, and he gave us a bit of advice. He said if a patient walks out with one exercise that they understand the reason for, and they can reproduce correctly, and has some therapeutic benefit, you've done a great job.
Yeah.
And I think this is it. I don't like to overload. We used to, back early days in practice, we used to hand out these sheets of 10 exercises.
Yeah.
To patients, go and do these sheets of exercise and 10. And the patient would come in and say, how'd you go to exercise? I said, I've been doing them, how often? Well, I did them the first night, and then I did a few the second night, and then, I haven't done any since.
It's like when they bring you the sheets of exercises post-surgery. You've seen those ones with the
yes, that's right.
with the drawings on them.
Yes,
and they've got 7 exercises or 10 exercises post-surgery. They've just come out of general anaesthetic.
That's right.
And they want them to learn 10 exercises. No, one exercise at a time. If you do that and you're competent and you do that well and you actually do it consistently, then you get the second one. Yeah, that's right. Yeah, and I think this is what it comes down to. I mean, it's horses for courses. Some people will take on more than one exercise. Some people really, you've just got to start very, very simply. And you just got to judge your patient, and that comes with experience. You judge your patient and work out who's going to be able to do what. Yeah.
Trying to teach somebody a glute activation, and this is the other thing, of course, that has changed over the years. When I went through, exercise rehabilitation really wasn't a big part of our training at all. We really didn't do much in the way of exercise rehabilitation. We did some lectures. We had some lectures from an osteopath and physio who came in and talked to us at the PSO. But we didn't do a lot of exercise rehabilitation as such, and there wasn't much known. I mean, you've got to bear in mind that nobody even thought about glute activation. Core muscle activation was another 15 years away at that point. 10, 15 years away at that point. And our concepts of pain were quite different. Our models of pain were quite different. Things have changed dramatically. 45 years on, things have changed dramatically. I mean,
I think in terms of glute activation, core activation. I don't know if you're the same. I don't like to split the body into parts.
No, that's right.
I think you end up falling into traps there, and I try to give exercises that are compound that use movement rather than muscle. If that makes sense. And I think that works a lot better than trying to activate a glute. I always find that if you ask anatomy to work, it'll work. And so if your glutes aren't activating, it's because you're not asking them to.
Yeah,
they're not dead. They don't just die overnight.
No,
like there's certain
the neural pathways. The neural pathways are there. There's no logical damage.
There's certain positions that you can place the body in. That will ask the glutes to work, and if they're not working, that means you're not asking that to happen. And so, as a practitioner, you've got to get that happening, I guess. Look, I want to move on and ask you about evidence-based practice, I guess, and and the current trend of the movement towards evidence and using evidence in practice, and how that's affected how we treat as osteopaths. Tell us your thoughts on that. Tell us your thoughts on the current evidence, I guess, the landscape in terms of how evidence should be put together. Is that really relevant to osteopathy? And then where do we go from there as a profession?
I had a very interesting conversation about 10 years ago with maybe more than 10 years, with a medical specialist called Nikolai Bogduk. Bogduk, and I haven't heard much of Nikolai Bogduk for some while. He may well be retired, I don't know. But he was one of those. I remember seeing him at various conferences. One of those speakers, one of those attendees at conferences who you.
He was at the University of Newcastle, I think.
He was. He didn't want to be a speaker when he was in the audience because he would get up and start asking you questions about all sorts of obscure papers and things that he'd read that other people hadn't read. And he wrote some very interesting papers on pain and types of pain and he wrote some interesting papers on treatment and the evidence base of treatment. He came and spoke to us at VU at one stage, and I remember talking to him after the talk, after his seminar, and we were talking about getting evidence for osteopathic treatment or manual therapy, whatever you like to call it. And he said, you don't have to prove how it works at the moment. Just prove that it works. And I think this is I think it's going to take a long time before we really start to understand how our treatment actually works. We don't. I mean, if you get Gary Fryer in at some stage and talk to him, Gary Fryer wrote 2 excellent papers, which I still refer back to, on the evidence of what evidence we have for osteopathic treatment of manual therapy and how it works. It's very different from how it was when I started as a student 45 years ago. And when I graduated 40 years ago, we really had nothing at all. We'd come against a GP and they'd say, look, you've got nothing. There's no proof, no evidence, nothing at all. Now we have stuff we can say, well, look, we do have evidence. Okay, a lot of it's not very strong evidence, and we still don't know how the whole thing works. I mean, how does manipulation actually relieve pain and improve mobility? How does causing a little separation between the 2 sides of the joint and causing some of the dissolved gases to become in a gaseous state and form a little bubble, how does that actually affect the mobility of the joint and improve things and reduce people's pain? The answer is we don't know. We've got no idea. But we can show it does. And,
Right.
So I think it's going to be... I think we've got to... Anybody who looks at it and says, oh, there's no evidence for osteopathy, is not looking at history. The history is that we've come from a place where there was nothing to a place where we have a certain amount of evidence now that we can actually put forward. I mean, if we go purely evidence-based, you said we're going to do only work on a purely evidence-based...
Evidence only.
Evidence only. We would actually sit in our rooms and give patients a booklet on back pain. Because that is the only thing that really has, as far as I remember...
The other professions are moving in that direction, John. Physios are moving towards... Yeah. I don't think they teach any more hands-on stuff at the university course level. Yeah. And they're moving towards exercise physiology. And so that's the trend. Yeah,
yeah. But why do patients come and see us? What you and I do manual therapy. Why do patients come and see us? I mean, if they go and see their doctor, for back pain, the doctor will do what? The doctor will get an MRI scan and tell them they've got ginger changes or a bulging disc, and tell them they've got, give them some medications and things to take. And why do they come to see us? Why do people?
Yeah, the feedback from patients, and this is very superficial, is that they'll say, "You've actually done something." Yeah, like you're doing something, physically. Like you're actually physically touching them. You're doing something. Yeah, and they're so happy about that because nobody's done something.
Yeah, I used to cycle with my GP a few times, and we used to have this conversation about being a GP and being an osteopath. And I always used to say, one of the great things about being an osteopath is most of my patients walk out of my room and say, well, that feels better. Now you can argue and say, well, that's just psychosomatic, it's placebo effect, anything you like. But the point is, as we come back to the original point I was talking about, or earlier point I was talking about, sorry, I'm running dry here. The lady who comes in from every 6 weeks with a stiff back, we're trying to prevent it getting these acute episodes. we examine her and we move her through some movements. We take her rock around and rotate her, throw her up the spine. And I thought the spine is stiff and difficult to move. And she says, "Oh gosh, I can feel that's very stiff." We treat it, we mobilise it, and we get her up after 20, 25 minutes, half an hour or so, run through the same movements. We check her spine, and she rotates better. And she bends her side better. And she eases back and says, "Oh, God, that feels so much better," And she walks out and she feels good. I mean, I know it's anecdotal evidence, but it is evidence of...
It's phenomenology as well.
Yeah, that's right, yeah. And it's subjective and objective observation of a change that's happening. But what I've actually done, I don't know. I mean, the old days, if we go back...
Well, you've done a lot, though. There's a lot of layers to your treatment.
Oh, yeah.
It's not like
huge,
you've done one technique.
No.
I think a lot of the studies try to measure the singular rather than the multiple.
Yeah, that's right, yeah.
And it's hard to say what particular thing you've done. And it's hard to say that it's that one particular thing only. It's probably the soft tissue in combination with the HVLA, in combination with the chat that you had with her, in combination with the stretch that you did on the pecs, in combination with multiple things that you've done.
That's right, yeah.
And how do you measure that? Well, you don't.
And I think
you've got to follow the patient.
That's right. You need to talk to someone like me and talk about what I'm observing in practice, and then get Gary Fryer in, who's done all the research.
They're longitudinal studies, we need
and talk to him, and
studies.
then get the feel for because Gary and I had a conversation some years ago about hypertonia, and I said, we palpate this hypertonia, and he said, well, we did all these studies, and we got patients, we put EMGs on them, we've never found hypertonia, and I said, well, what is it we're palpating? He said, well, I don't know, but it's not what you think it is. It's not an increased reflex activity causing the muscle, the gamma system and the alpha system coming out of the anterior horn to increase the tone in the muscle. I said, well, that's fine. That's the model I'm working with at the moment, and I'm still working with that model now. Give me another model to work with. Give me something else to work with, and I'll work with it. But at the moment, that's all I've got to go on. But the point is, we are palpating restricted movement and tight muscles. We all know it. And, it's that wonderful thing you have, and you must have it as well, when you get some experience. You can go down a patient's spine, and you can get that interspinal space, and you get to a point you go, that's tender. And the patient says, yeah, it is. Yeah. And you go, oh, that's tender. Oh, yeah, that is.
Yeah.
And that's tender. And the patient said, what are you feeling? And I said, I don't know. I just know that's tender. I've been doing it for 40 years. I know that's going to be tender. That's treated. If I get that moving, you're going to feel better. And it becomes almost an intuitive thing as well, and that's a hard thing I think for graduates to appreciate.
And do you think that when you lay a patient down, John, you perform your treatment, you're somebody who's garnered a lot of experience. Do you think that Jon Pitcher doing a HVLA and soft tissue on a patient is going to garner better results than somebody who's been practicing for 3 months? Like, that's an easy question for you to answer.
I hate to blow my own trumpet on that one.
It's not about blowing your trumpet. Where I'm going with this is that when we get research done, when we get research done, we're invariably relying on
and that's
people
the fundamental problem.
Like yourself, to perform these
Absolutely
things.
Right, because people like me don't particularly want to go and spend hours treating people in practice. Plus, we've got practice to run and we can't afford it. I mean, if they're going to pay me $300 an hour to do it, then I'd think about doing it. But they're not going to. They're going to pay me $50 an hour if I'm very, very lucky. And maybe throw in a free cup of coffee if I was.
And I don't think you care enough. I think you're getting enough results with patients, and you're living a happy life. And I don't think that you it's not like you have this. You know that it's working. It's not like you're searching. Right, you're not going down a rabbit hole. All right.
But I think you see this with the students, either fourth and fifth year students. They're amazed me. Often they're amazed me. Come in and you take over a bit of treatment for them or something and just show them how to do something. And I always love a patient in the clinic a teaching clinic and we say, okay, well, they've got this. Let's just treat one thing. And let's re-examine it and see what difference it makes. And it's amazing when you just do one thing. Let's just stretch out the QL on that side, and the costo-iliac fascia and tissues on that side, and just spend a few minutes doing that. And let's re-examine them and see what happens. They get up and they go, oh, it's better.
Yeah.
I said, yeah, look, you don't have to do this. And students go, oh, wow, okay. It actually works. It's fantastic.
Small wins go a long way.
That's right, yeah.
Yeah. One thing I want to add as well is that I think it's a bit of a burden if we place the load of evidence of a profession on either students or new graduates or people that have been in practice for like 5 years or so.
Yeah.
I don't think that's the right thing for a profession to do.
No.
On the other hand, as you just discussed, someone like yourself is probably not going to be overly interested in going down that path. But there are people that down the track develop this urge to want to do research, and that's fantastic.
Yeah.
And you mentioned Gary Fryer, and I think he's a great example of somebody who's a real osteopath that's practiced osteopathy, that knows osteopathy, that's moved into clinical research. Another one that I talked to was Rosalba Courtney. Rosalba's doing a lot of great things with breath work.
That's right. Yes,
she's done a lot of great research.
Right,
and these people have a passion for it, and they're the ones that we should be encouraging to kind of do the research. I think that's that's where you hit the money on, the nail on their head, I guess. With with that. So that's my 2 cents on that. But moving on, I want to ask you now a bit about the future of osteopathy. You've seen it grow over the last 40 years, especially in Victoria. There's been a bit of an explosion in terms of osteopaths going to different fields of practice like aged care and occupational health and safety and sports and so forth. Where do you think we need to? Do you think we're doing things right in terms of marketing osteopathy to the public? Are we putting the right message out there for people to kind of want to see osteopaths? Like how we, do you have anything to add there? Any advice or any kind of about the future of osteopathy?
I have confessions about marketing and advertising were the things I least enjoyed about a practice. I absolutely hated. I hate marketing. I hate advertising. I hate promotion. Which is
you seem quite passionate when you talk about osteopathy.
Yes.
So I'm assuming when you discuss osteopathy with your network of people, there's a certain message that you want to give.
Yeah.
And that's marketing, John. Yeah. Like, you're giving that message. So tell us about that message. Like, what would be John's message to the world, I guess?
Oh, gosh, that's a very interesting question, isn't it? That's a very interesting. What would I?
What's your message to the world about osteopathy? Like, how would you like the public to view what we do so that they can embrace it? Like,
I think again, it's this manual therapy. We're back to manual therapy.
Hands on.
We are. I think it's slipping. I fear it's slipping. But for a while there, I would argue this. If there's a physio or chiropractor here, they'd probably jump down my throat. I would argue that we were the best at it.
Mm-hmm.
We really did that. We were the best at manual therapy. And I still think we have the potential to maintain that crown.
Mm. There's a point of difference there.
But I think it needs, and then probably what it needs is if only we could get people like, like myself or some of the practitioners of my ilk or perhaps just below to come back into the teaching field and teach. I'd like to go back and teach first year technique. That's what I'd like to do. If a university turned to say to me, you can have any job you like, we'll offer you a job. I'd say, right, let me go in and teach first year technique from the base. I love anatomy and I'm quite happy to go and do some anatomy work. I like clinical teaching. I was getting a bit frustrated by the end. What I'd like to do is get those students right from ground zero and teach, good soft tissue, basic soft tissue, good basic joint examination, palpation,
And
now,
principles.
yeah, and principles. And I know there's people who are teaching it. I'm sorry if they're listening to this, and they're probably saying, "But yes, but we do that," and I respect their opinion on that. It's not what I saw in the clinic.
Well, the proof is in the outcome, John.
Yeah, that's right.
I'm talking to Gary Fry actually tomorrow night.
Right. Okay.
As we're recording this today.
Right.
I'm actually talking to Gary tomorrow. So I will tell Gary tomorrow, who's heading up Victoria University.
Yes,
Gary,
that's right,
John wants to teach.
Yeah.
First year. I'll put in a job application for you, mate.
Yes,
We'll see what happens.
Let me come in to teach first year technique, but he'll say, "Oh, I don't think so."
So your main worry is really for the future of the profession in terms of being manual therapy.
I think
that's slipping.
I think that's slipping. And look, that may be the natural progression. I mean, this is, I'm at the end of my professional life. Really, I don't think I don't want to retire yet. I'm really And this is
are you a member of Osteopathy Australia? I mean,
yes,
you're still a member.
They're
the professional organisation that we need to speak to and say, look, this is the message we need to get out there to the public.
I wrote an article for OsteoLife about 3 or 4 years ago about this, and I likened manual therapy to the whole therapy side of things to airline travel.
Right.
I said there was the basic airline travel that was the Boeing 707 and a Boeing 787 literally travel at the same height, at the same speed. They do exactly the same job. The experience for the patient inside, for the person inside, the passenger side, is exactly the same, whether it was a 1958 Boeing 707 or a 2024 787. Concorde came along. Concorde was amazing. Concorde blew our minds. I saw one of the first test flights of Concorde as a child. We went out on the playground and watched it fly over our school. It was absolutely mind-blowing. But it came and went. Because the best way of flying people around the world is in the equivalent of a modern Boeing 707.
Yeah.
And I see the same with manual therapy. Manual therapy has been there for millennia, as we talked about. It's still one of the best ways of treating people who have musculoskeletal pain and dysfunction. And I just don't see that changing.
There's nothing new under the sun.
You can bring in all you like, and you can bring in all the, we can do dry needling, and we can do all sorts of wonderful things. We can bring in differentials and shockwaves and do all sorts of things. I'm sure they have their place, just like supersonic travel. Supersonic travel probably will have its place again. But at the end of the day, I just don't think you can beat good, hands-on manual therapy. And you know what? A patient comes in to see me after 40 years, and they walk out feeling better. I still get a real kick out of it.
Yeah, good.
It's I just go, oh, geez,
that's amazing to hear.
I made them feel better. What a great thing. I walk out at the end of the day, and I know there's a whole lot of patients who are walking around up there now feeling better because their neck now moves better, because I made them better. They can turn their head. They can do things. They can get back to walking the dog. They can go back to making love. They can do all sorts of things. Because I got their back moving, and I got their hips moving, and I got the bit of strengthening here, and I got I think there's a lot going on there, but I think at the end of the day, we are good manual therapists. Manual therapy is where our expertise is, and that's
we were great manual therapists, and I think we're slipping a little bit. I have to agree with you, and I think we can still be great manual therapists. We just need to make sure we don't lose that in our education. The problem in front of us at the moment, John, is that the regulator, I think, is aiming at trying to make it a really level playing field. And they do that also through course accreditation. And so we need to come up with a solution as a profession, maybe an internship program, maybe some kind of external clinic that we run as a profession that exposes students to good manual therapy, hands-on stuff that you discussed. But we need to really come up with some solutions as a profession. Mate, I want to say I've really thoroughly enjoyed chatting with you tonight, John. I think there's definitely a second episode in this.
Right.
We need to get
most
some more
of my students
thoughts.
would tell you I have no problem talking about osteopathy.
Yeah, no, that's great. That's what we're after. I really enjoyed it. I feel like I'm one of your students.
Thank you.
And so I'll I'll hit you up for a second episode.
That'd be fine. I'm always
somewhere
happy
down
to
the track.
chat. Yeah, always happy to talk.
And what I want to do, I think, in the future as well, is do some round table stuff. Get you, maybe Gary Fryer, maybe I'm just throwing names out there, but get yourself and some other people together that have been around for a while and are kind of involved in different aspects and do a little round table and see what we throw stuff against the wall and see what sticks.
Yeah, that's right.
But I thoroughly enjoyed tonight. I want you to hang around with me here for my Success in Practice students.
Yeah, sure.
For the public listeners, thank you everybody for listening. We'll thank Jon for his time, and everybody enjoy this episode and share, like, and subscribe, and thank you for joining in.
Thank you.
Okay, Jon, for the Success in Practice students, I want to ask you some questions specifically around your experience around case history. So, give us a really good tip. Maybe not something singular, but like as an overall.
When you asked this, when I saw this come up, I thought, I don't have one tip.
Yeah, it's not like one tip, right? But as an overall kind of, I guess, thought process.
Yes.
Where's your head at when it comes to taking a successful case history? Like, if it's one thing that if you could speak to a new graduate and say, look, try this or have this mindset when you're taking a case history and you'll get a better result, what would that be?
I think to go in, I've been a clinical teacher for many, over 30 years, and I have listened to students come out with case histories, present them to me, and almost invariably, particularly early on in the year, said, have you actually come up with any ideas from that? Have you just taken, I think, don't just take a case history for the sake of taking a case history. Go in and actually ask and listen to what's going on and try and work through what's actually happening. It's an academic process you've got to work through to try and establish what has actually happened, what's going on. And students would come out and they'd have this case history, and we'd say, well, what do you think's happening? And they go, I don't know. It's they learn to do the thing, and I think we practitioners still do this. I think case history is one of is when I worked on the registration board, I sat on the hearing panels. We had to sit on various committees that looked at complaints. And Brian Nichols was involved in this as well. He did a lot of work on this. And we both said the same thing when we did talks to graduates and fifth-year students. In almost every case, I'd say every case we saw, the case history was deficient. We had to look at the case history, look at what happened in the consultation, try and deconstruct what happened in the consultation from the case history. In every case we saw, case history was differences. So I think the first thing is take a thorough case history, sit down and listen to patients and go through it and really trying to get to the bottom of what's going on. Don't do the rudimentary case history, just write down a few details and then just go firing off into a rudimentary examination and then say, treatment. Don't shortcut any of it. And
Right.
That takes time. And that's one of the reasons why I work the time frame that I do, because I just find I need that time to actually go through and work through the whole process and work out what's going on.
Tell us about control within a case history taking. Like, how much of are you somebody who likes to let the patient just freely discuss what they're going to discuss?
You can't.
Or do
can't.
you maneuver them and control what goes on?
I don't think. I think you have to have some control over the whole thing. You can't let the patient. You can't just say to the patient, "What's wrong with you?" and let them just tell you. You do have to let go. If the patient wants to tell you what's going on, they walk in and they've got the whole thing in their mind. They are looking at it and saying, "Oh, what am I going to say to him? What am I going to tell him?" So if he comes, they come in and they say, "I want to. I've got this and 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 this is going on. This is going on." You've got to let them go and you can't let them go too long there. You've got to say, okay, let's just stop it there and let's come back and come back to the beginning. So what are you actually feeling? What's actually going on? What are the actual symptoms you're getting? Okay, now when did they start? So you have to direct the case history learning, case history taking, certainly. You can't just let a patient tell the story. Although you have to let them fulfill that need when they first walk in the door, because they've always got this story to tell.
Yeah.
But you have to take control and direct it yourself, but not lead them too much.
Okay. And in terms of formulating your diagnosis, what are some of the, I guess the same. I'll put the same question to you in terms of actually getting to a diagnosis. And we did discuss this earlier off the air.
Yeah.
But making sure that your diagnosis is as accurate, I guess, as you can make it. We can never be totally sure.
Yeah.
But being as accurate as you can and as concise as you can, what are some of the I guess, thought processes behind that? How do you go about achieving that?
I think it's one of these difficult things where the models have changed over the years. I say when I was a student over 40 years ago, we had very, very rigid models about pain. Pain came from a structure and went by a direct path up to the cerebral cortex, sensory cortex, and pain at that point was caused by a structure at that point. And of course, as time's gone on, our whole concept of pain has changed, in the way that pain is generated, in the way that it's altered and changed on its passage to the cerebral cortex, its interpretation has changed. We now know a lot more, and it's like so many things in life, the more we look at something, the more complex it becomes. We try and unravel the whole thing, and we just end up with more and more knots. And pain is the same problem. And I'm trying to work out what pain's coming. I work in casualty as a nurse back 45, 50 years ago. We have a patient, I remember a guy came in having fallen off a motorbike, and there's a piece of tibia poking right through the skin. Now, the guy's got a broken tibia. But there's no two ways about it. You don't need an X-ray even to diagnose that. It's there. It's sticking, looking at you. You can actually put a finger on it, But somebody comes in with back pain, and they said, "Well, how did it start?" "Oh, I don't know. And people always come up with ideas about how their pain started. "Oh, I lifted the dog into the car. Oh, is that when it started?" "No, it was about 3 days later, but I'm sure that was it." Said, okay, there was nothing to do with that. Okay, but this sort of thing. So you've got to really nail down what's going on and things. So when it comes to diagnosis, you just can't sometimes say what is actually the cause of the pain. Does it matter is the other big question you've got with that one. If we establish it's a mechanical problem, We say, okay, we don't have a pathology here. We don't have a tumour growing in the spine. We don't have a fracture or some major trauma or any problems. We've got a musculoskeletal issue going on here. What are the predisposing factors that led to that? They're going to help us with managing it and perhaps preventing it and dealing with it. But what are the maintaining factors here? What is actually maintaining that dysfunction and that loading and that strain? And how are we going to deal with that? And that's where you're going to. That's really that for me. That's that's diagnosis.
That's osteopathy.
That's right. It is. It's osteopathy. You're absolutely right. And that was what I was taught at the BSO. You know, I mean, people thought, oh, yeah, Jon Pitcher bought the diagnostic model. You know, it's an antiquated diagnostic model to VU and RMIT. He didn't. They bloody taught me that at the BSO. You know?
Yeah, no, that's osteopathy.
It's a fabulous piece. It was taught to me by old osteopaths at the BSO, you know, who've been in practice for 20, 30 years. You know?
That's the point of difference between what we do and what other professions do.
Yeah.
That's why they come and see us. It's because, you know, we understand there's a pattern, there's a strain pattern behind what's going on. And we're bloody good at sorting it out in terms of understanding it anyway. And then you go and develop the skill set to unwind it.
Yeah, that's right.
You know, but that thought process, it's the way we think. It's not what we do. It's just how we think, and that's what I'm trying to get across to the students as well. Is that the way you think really matters? It's actually almost all that matters.
Yeah, that's right. It is very true. Very true. Yeah.
So that's it's interesting that we're having this discussion, John, because I think my educational background is probably a little bit different to yours. I'm not from I don't have that English kind of influence, but yet we're kind of arriving at a similar place.
Well, I imagine some of the people who taught you probably were taught by people who I taught. Who were the RMIT graduates who taught?
Oh, look, there was the RMIT graduates that I had when it was more in clinical supervision. So Liz Howard,
right? Yes.
Kate, I think. Arfi, I think she's changed her name now.
Kate Arfi, I know Kate Arfi.
Yeah. They were great, and they were.
Well, see, they were taught by people like Bruce Duncan and Mick Kelly.
Yeah, that's right. But the thing is, for me,
I taught Bruce Duncan and Mick Kelly. So,
well, that's good.
So we're all thinking on really long same lines.
And I mentioned my influences were by John Abdullah and Ann Cooper, and they were taught by Ivan and Peter Cash.
Yes, that's right. Yes.
And that's probably a little bit of a different school, but I think if I sat you down with Ivan, God rest his soul, he's not with us anymore.
I've known Ivan. I've worked with Ivan.
Yeah, so you'd probably arrive at similar somatic dysfunction patterns.
Yes.
Because it's principles, whether you learn it in England or you learn it in America or you learn it in Bangladesh. You don't really, But anyway, I'll move on to the final question because I know you've given us plenty of your time tonight.
Okay.
Technique. Tell me a bit about technique. So when new graduates or students want to try to master techniques, where do you think they go wrong? And then what should they do to maybe not speed up the process, because the process will be the process, but to make it maybe not as bumpy, as they would like or they wouldn't like. Losing some of that anxiety they're getting in technique down.
Yes, that's right. I think one of the big things that I remember talking to students about at VU and RMIT was this feeling about manipulation, that you had to get a click. And they'd feel like terrible failures if they didn't get a click. I said, well, I'm 40 years in, I still don't get clicks all the time for every joint I go for. You go for a neck sometimes and it just goes blup. Yeah. And you think, oh, okay. And sometimes I think you've got to. Because I taught HVLA, I still have that ability to break the whole thing right down to its basics. And sometimes I've got to go back and break the thing right down to basics. If I've got a neck or a lumbar spine that doesn't want to wind up, I go back to the basic. Okay, let's start. Okay, let's take up the first lever, take up the second lever, bring it up. Let's put a bit of compression, a bit of distraction. Where are we going to go for this? And I think this is it. I think it's realizing that you can play about with the leverages and things. But core-wise, I would say to them, it's the thing that I think we're missing in the courses at the moment. I would like to see HVLA taught as it was when I went through, and as it was when we taught the first few years at RMIT, at Philip Institute. it's taught in the third year.
That's how we got taught.
Third year is where you learn HVLA. Not as it is now at VU and RMIT. This is my opinion. Okay, other people will disagree, and I respect that. You teach them the basic handling. You teach them soft tissue work and basic joint articulation and palpation.
Well, it's a process, isn't it? Like, it's you got to build up skill.
Second year, you hone that. More advanced work. You start to do a bit of MET type work. You do more work on articulation. You start to teach them to apply the technique to certain.
You engage barriers as well.
Yeah, you engage barriers, and then by the time they get to the second year, they can feel the end range of movement of joints. They feel they can examine a joint. So you actually take them through an exam at the end and say, "Show me how you examine the neck." And they go through and they start. C1, 2, they rock backs and forwards, side to side, or OA, so C1, 2. C1, 2, they rotate. Then they come down, they look at rotation and side bending all the way down through. Whereas we get this situation in fourth year at the uni where they come in and they go, they're just doing sort of a lateral side to side, toggling of the neck. And you say, well, what are you feeling? Oh, I'm just feeling the general movement of the neck. And they've got no idea where they're going to manipulate.
They don't know the levers. General movements.
But they haven't been taught to actually get on and actually feel which joint needs manipulation.
Yeah.
And I think that's what I would be saying to them. I said, get your basic skills up. Get in there and examine. I often do this with graduates. Actually sit them there and say, right, let's go through and examine a neck and have a feel of it. Let's sit the patient there and feel each segment right the way down, how it moves on the one below and above. Now, which one is that one? That's not moving. You feel it. Yes, that's not moving. Is it tender? Oh, yeah, it's tender. How does the muscle feel? Oh, I feel pretty tight. Okay, let's lie them down. Now, manipulate that joint. See what happens. Oh, we got it. Okay, fine. And it was easy to manipulate. Yeah, of course it was, because it
needed it. Yeah,
it needed it. And I sit them up. Now I feel it again. Oh, and the patient, the model goes, oh, that feels better.
Yeah.
And they've gone. You've just taken them into a whole new world. You've just opened their universe completely. They've gone.
You're definitely right, especially about the progression of it. Learning good soft tissue barrier engagement is the first step, I guess.
Yeah.
And then you get into your second year, and then you learn about joint barrier engagement.
Yeah, that's right. Yeah,
and then you'll finally get to your third year. Then you're ready to go through that barrier.
That's right. By the time you're third year, you can teach the whole third year. You can spend the whole third year teaching all the HVLA, because they don't need to do a lot of basic stuff. A lot of basic stuff.
Yeah.
You can just say, okay, now instead of taking it round and open the joint, let's take it through and then add a bit of side bending. Let's lock it instead. Don't take it to don't do it. Let's lock it up and see how we go. And then this.
And I think there's not enough credit given to springing. I always talk about springing.
Yeah.
Especially with lumbers. So one of the times that really frustrated me as a student, I was trying to get this lumbar roll technique, and John Abdullah, who taught me, said, you know what? He broke it down like you said. Just break it down to all the levers, get it right. He said, you know what? Just spring that joint. And I sprung it, and he goes, all right, stand up. We stood the patient up, and he goes, retest. I'll retest it. I'm like,
yeah, that's right.
It's better.
Yeah, that's right. Yeah, absolutely.
He goes, look, sometimes you'll get it. Most of the time, the more experienced you become, you'll get it. If you don't get it, you've sprung the technique and you've retested.
That's
it's not about the pop. It's about the fact that you've made the improvement in that segment.
That's right. Yeah.
So totally agree with you.
I can see now.
John, you've been extremely gracious with your time.
That's okay. It's good.
So on behalf of the students, I want to thank you for tonight and for this little extra tidbit of information.
Yeah.
Where can we reach you if we want to get in contact? Like, is it? Do you want me to just put your email address in there? Or?
Yeah, absolutely. Yeah. And if anybody out there wants to come and do, I love doing small group technique.
Right.
So
any of the students here in Melbourne,
advanced age, any students want to do?
Yeah, any students in Melbourne, hit up John, give John a call.
Classic, old-fashioned soft tissue work, non-lubricant soft tissue work. They want to come and learn that. Tell them to get in contact with me. I get six students.
Where's Ferntree Gully?
Ferntree Gully is just out in the eastern suburbs of Melbourne. It's very easy to get to.
Okay.
Yeah, there's freeways nearby and all sorts of stuff.
Yeah.
And yeah, that or peripheral joint HLA. Again, they're not
Great.
taught this stuff. We can do, I mean, the clavicle,
Mm.
no students these days don't learn how to treat clavicles. And
Yeah.
yet I spend, every time I get a shoulder or neck, then one of the first things I go for is the clavicle.
Yeah. Right.
It's such a vital part of the body.
All right. Well, stay on the line with me, John. But thank you for tonight, and
That's
we'll
okay.
do round two.
Yeah, sounds good. Beautiful.